Hello, everyone. My name is Justin Joy, and welcome to our podcast. We'll be presenting a case study and discussing for and against the very challenging topic of assisted suicide and euthanasia. We'll also be discussing different ethical issues a Christian physician may face when caring for such a patient and how to deal with this particular difficult topic. To make this more relevant and understandable, we'll be using a real case study taken from a book called Medical Ethics and the Faith Factor, a handbook for clergy and healthcare professionals by Robert D. Orr. And now I will present the case study. David is a 34-year-old man who has been on the ventilator for 9 years. He was readmitted to the hospital 2 weeks ago for treatment of recurrent pneumonia and has improved. He asked yesterday if his ventilator could be stopped. 9 years ago, he sustained a neck fracture in a diving accident that left him quadriplegic and ventilator dependent. He went to a rehab facility where his family learned to care for his medical needs, and he was discharged home on a ventilator care. His pulmonary situation was stable for several years. He was able to be off his ventilator for several hours at a time and go out in his van with his friends. However, in the past 2 years, he has had 10 hospitalizations for atelectasis or infection. His secretions have increased so that he requires suctioning several times through the night, and he's no longer able to be off the ventilator for even short periods. He has vigorous treatments with antibiotics, chest physical therapy, and repeated bronchoscopies, and it is a consensus of his care team that his pulmonary situation will not improve and will likely steadily deteriorate. He has had excellent care from his mother and his sister with help from nursing home attendees 12 hours per day. He has a voice-activated computer that facilitates many personal tasks. He has been very involved in his care, and his nurses describe him as a thoughtful, intelligent, and self-assured patient. Prior to his illness, he attended college and was a history major and enjoyed classical music. He has had several supportive friends visit him regularly. His parents divorced a few years ago after his accident. His father and only brother live out of state. The patient states that his sister has put on her life on hold to assist with his care, and for this he feels grateful but not guilty. He has been thinking for the past 8 months that he wants to stop supportive treatment so that he can die, but articulated this to his family and care team yesterday. On examination, he's alert, articulate, and in no apparent respiratory distress. He's able to speak a few words at a time using a speaking valve. He says his life as a quad was tolerable up until 2 years ago, but the progressive pulmonary disease has made it intolerable. He would continue treatment for another 9 years or more if he could return to his condition prior to the progressive pulmonary deterioration. He is now frightened of suffocating and wants to avoid that. He would take an overdose of a sedative and ask someone to disconnect his ventilator, but he recognizes that this is not permissible and wants to work with his team to find the best comfort care possible as his disease takes his life. He reports that he's not depressed, though he knows what it feels like to be that way, as he was despondent for several weeks after his accident. Now I invite Dr. Jason James, clinical pharmacist from New Jersey, to share some defining terms relevant to this case study. Dr. James.
Thank you, Justin, for that introduction. As we prepare to dive further into the case, it's important to define what exactly euthanasia is and how it differs from other concepts such as assisted suicide as well as palliative care. The word euthanasia is derived from the Ados, meaning death. Put death. Euthanasia is the of death in a patient that we'll discuss. One is called active euthanasia, and the other is passive euthanasia. Active euthanasia refers to physicians' deliberate act to end an incurably or terminally ill patient's life, usually with the administration of lethal drugs. Now, active euthanasia can be further classified into three categories known as voluntary, non voluntary, as well as involuntary euthanasia, and they differ in the matter of consent. Voluntary euthanasia occurs at a patient's request. Non voluntary euthanasia is when a patient's unable to make that request due to certain situations such as a brain injury, maybe a coma, or even just being too young. Involuntary euthanasia, on the other hand, is a compassionate act to end the life of a patient who's perceived to be suffering and could make a decision, a voluntary request, but hasn't done so. Passive euthanasia, it refers to withholding or withdrawing treatment, which is necessary for maintaining life. And we'll touch a little bit more about that later. So what is assisted suicide? Assisted suicide occurs when a physician, or someone else, helps a person takes his or her own life by giving advice, writing a prescription for a lethal medication, or assisting the patient with a device which allows them to take their own life. The physician or another, they lend their expertise. However, the person themselves is the one that does the act. Now, traditionally, medicine has been focused on extending life. However, as death approaches, extending life may not always be in the best interest of the patient. There are many treatments and interventions that can artificially extend life at the end. This includes certain medications, artificial nutrition, even treatments such as dialysis, transfusions, even ventilation for breathing. So how can we differentiate between withholding treatment and withdrawing treatment? Well, withdrawing treatment involves removal of therapy that has been started in an attempt to sustain life, but is not or is no longer considered effective. Whereas withholding treatment is the decision not to make any further therapeutic interventions. And the most frequent example of this is a do not resuscitate order, a DNR order. The actual decision to discontinue or decline treatment, it rests with the patient's family, or a substitute decision maker. It's important to remember that declining or discontinuing treatment that artificially extend life doesn't mean that symptom control, such as pain management and emotional support, stop. Care and treatment focused on maintaining comfort, they continue, allowing the patient to die naturally from the disease. The last term we're going to define before moving on to the case is palliative care, and it's a specialized medical care for people living with serious illnesses, such as cancers or even heart failure. Palliative care is based on the needs of the individual patient, and it's not always on the particular prognosis. It's appropriate at any age and at any stage in the serious illness, and it can be provided along with curative treatment. I hope that we've gotten a better grasp of some of the terms associated with euthanasia, and with that, we're going to continue with the case assessment. Thank you.
To discuss reasons in favor for euthanasia, I invite Dr. Benson Abraham, who serves as a hospitalist in Massachusetts. Dr. Abraham.
Thank you, Justin, for the introduction. Euthanasia, as we know from the Greek word meaning good death, is the practice of assisted suicide with the intention of relieving pain and suffering. Euthanasia is also known as mercy killing or physician-assisted suicide. With regard to euthanasia, there are multiple viewpoints, and surveys taken in the United States indicate that about 46% of the physicians agree that voluntary euthanasia should be allowed for certain situations, whereas 41% disagree altogether, and 14% believe that at certain circumstances, euthanasia should be acceptable. So I'm going to discuss the arguments or reasons why people think in favor of euthanasia. I'm going to put it under 8 points. The first point is that people have the explicit right to choose and therefore have the right to die in a particular circumstance. Number 2 is everyone has a right to a good death. and therefore a good death must not be denied to those who want one. The third argument is euthanasia is not immoral because the beneficiary is the patient who generally is terminally ill and is in extreme pain or agony. The fourth argument is that euthanasia protects the selfhood and human dignity. The fifth point or the argument in favor of euthanasia is that euthanasia do not harm others. The sixth argument is euthanasia does not shorten the lifespan by as much as it is portrayed. There was a Dutch survey that was conducted in 1991 that showed that 86% of euthanasia cases only shortened the life of the patient by a maximum of 1 week. The standard time it shortened their life was only by few hours. The seventh argument is that euthanasia saves life as it is properly regulated. If it is properly regulated, it provides a protected and regulated framework with which doctors must first obtain explicit consent before conducting euthanasia. This same framework makes it more difficult for those seeking to perform euthanasia with impure or irresponsible intentions. The eighth or the last argument which I'm putting for euthanasia is with regard to the Hippocratic Oath. Hippocratic Oath supports euthanasia. The reason is, in cases where it is a choice between intense suffering or death, it can be argued that a physician is doing more harm to the patient by not allowing them to die. In fact, the choice is between intense suffering and death. And as in any other situation, we need to calculate the benefits and harms. And if something is harming the patient, a physician is not supposed to do it. If something is benefiting the patient, physician is morally supported to go forward with the procedure or the intervention. Thank you.
To discuss reasons against euthanasia and assisted suicide, I invite Dr. Sini Paulos, who serves in family medicine in Massachusetts. Dr. Paulos.
Hello, my name is Sini Paulos. I'm a family physician from Boston, Massachusetts. In the next few minutes, I would like to present several arguments why we should not support euthanasia or physician-assisted suicide. Currently, right to assisted suicide is not a constitutionally protected liberty, and even if it is legal, is morally wrong. First reason is the sanctity of life. The Bible says in Genesis 1:27 that we are fearfully and wonderfully made by God. Human life has an intrinsic value given to it by God and does not depend on anything else. Thus, a life that is disabled or even bedridden is not worth less than another life. Euthanasia undermines this by asserting that life can become not worth living. We do not choose the day we were born, and we cannot choose the day we die. The second reason is that human beings do not have the right to take life. The sixth commandment says that thou shalt not kill. Assisting a patient in suicide can be deemed as killing that person and can be a violation of God's commandment. Granting right to euthanasia can be a slippery slope, as lines between voluntary and involuntary may be blurred. There remains a real possibility of extension of euthanasia to children, those with mental disabilities, elderly, people who can't speak for themselves. This is the case in Netherlands, where there was non-voluntary cases of euthanasia to terminate lives of disabled infants. Ultimately, it may not be possible that euthanasia is not done for the best interest, or euthanasia is done for the best interest of the patient. Society can use euthanasia to end lives of vulnerable people who may be considered burdensome or not valuable. euthanasia may be unnecessary. With so many advances in palliative and hospice care, pain management, if the medical teams and the caretakers put their best efforts and make sure adequate medical, pain management, emotional, and spiritual support is available to the patient, he or she may be content with this life and may not wish to end it. On the flip side, when legalized euthanasia can become an accepted way of dealing with serious or terminal illness, as seen in Netherlands, it can hamper advancements in palliative and hospice care. Also, with the rapid advances in general medicine, there may be treatments available to patients in the future that could be curative or at least reduce their illness severity. This will not be available to those patients who choose to end their lives early with euthanasia. Physician role as leaders. Physicians have a unique responsibility to help save lives. And youth-assisted suicide may undermine their commitment to save lives and also to show real compassion to the patients, address pain and other issues that's facing the patients. Also, physicians exert undue power and influence on the patient and their family's decisions. And there is a possibility that personal biases and prejudice can play a role in these decisions in a negative way. It may also expose vulnerable patients to pressures to end their lives, such as pressures by families or loved ones for selfish reasons, sense of guilt, a sense of abandonment, a sense of lack of worth. These all could be reasons for them to pursue euthanasia. The value of human life in all forms and stages is central theme of the gospel, for it was the very purpose of Christ's birth and resurrection. To fail to respect human life at any point marks the very essence of Christ's mission to humanity. Thank you very much.
To discuss the normal practices right now in hospitals and in the ICU setting regarding euthanasia and palliative care, I invite Dr. Tony Joseph, who serves as an internist in Oklahoma. Dr. Joseph.
Thank you, Justin, for that intro. So general practice for physician-assisted suicide is currently permitted in 10 states and the District of Columbia. On average, physician-assisted suicide accounts for 3 out of 1,000 deaths in these states. Physician-assisted suicide differ from euthanasia in the fact that there's a backing of a controlling legal authority. These states have adopted the Death and Dignity Act, which was initially passed in 1997 in the state of Oregon. In the outpatient setting, these rules apply to the attending physician. They have to initially determine whether the patient has a terminal disease and is capable of making this decision voluntarily. They have to ensure that the patient is making an informed decision and they are aware of their medical diagnosis, their prognosis, their potential risk of taking medications, and the result of taking those medications. They are also to be given feasible alternatives, including comfort care, hospice, and pain control. The referring physician should consult an outside physician to determine the medical confirmation of the diagnosis of terminal illness and determine that the patient is capable of making the act voluntarily. The physician should also give the patient the right to see a counselor. It is also recommended that the patient also inform their next of kin of their decision and that the patient should have someone available at the time of the act to be able to assist them if needed. And the patient should be informed that they could rescind this act at any moment. All paperwork, including pharmacy prescriptions, all of which have to be complete prior to doing this act. The patient should be able to rescind this at any moment, and patients that are inpatients have a different approach, including being able to see other consultants, including palliative care. The patient should be treated for symptom management, including difficulty swallowing, difficulty with controlling pain or dyspnea, delirium or agitation, nausea or vomiting, constipation, and or pharyngeal secretions. This could all be done by the palliative care services as well. And the whole idea is that symptom control at the end of life can allow patients to progress through the dying process in a safe and dignified and comfortable manner. Thank you. Thank you, Justin.
I invite Dr. James Samuel, who serves as an internist in Connecticut, to discuss from a Christian perspective how should physicians respond to patients that request voluntary assisted suicide. Dr. Samuel.
Thanks, Justin. Physicians must be ready to respond to requests from patients for assisted suicide when there is considerable suffering from terminal illness. There are a few points that they should keep in mind while responding to such requests from patients. Given the improvements in palliative care, currently most requests from patients are triggered by loss of their dignity, independence, and loss of control of timing and manner of their death. Those requests can also be from psychosocial problems, spiritual crisis, or fear of abandonment. Physicians need to screen patients for major depression. Physicians should evaluate such patients carefully and try to mobilize all the resources to care for such patients. Most patients would find life worth living if their pain and suffering is alleviated. Physicians should consult with palliative care specialists, psychiatrists, psychologists, social workers, and chaplains as needed. Physicians should communicate with empathy, allowing patients to understand that their concerns are heard of. Some patients look for assisted suicide as they fear unwanted life-prolonging interventions. Physicians need to reassure patients that decisions to forego life-sustaining interventions will be respected, provided we screen for depression. As these cases can often be so stressful, a second opinion with a trusted colleague is generally helpful. Physicians, as believers, should not participate in assisted suicide or active euthanasia against their conscience or religious beliefs. When communicating their refusal to provide assisted suicide, they should show empathy to patients' plight. They could say that, "I hear that you're deeply distressed by your illness. I will try my best to relieve your suffering, but I cannot help you kill yourself. My conscience won't allow me to do that." But there are rare situations when assisted suicide might be justified. But the combination of the following circumstances have to be there in order to make a strong case. Patients should have incurable conditions like ALS causing unrelenting suffering. Patient is experiencing intractable symptoms like intractable bleeding, inability to swallow secretions. Physicians has provided optimal palliative care and has ruled out depression or any psychosocial crisis. Patient's request is voluntary, and he is fully informed that they have discussed with his family members, friends, and clergy. Physicians has a long-term relationship with the patient that started even before the patient requested assistance with suicide.
To further discuss different ethical issues as a Christian physician while dealing with this particular case, I invite Dr. Joseph Kuruvilla, who serves as a pediatric cardiologist in Connecticut. Dr. Kuruvilla.
We have heard the details of the case, defined euthanasia and assisted living, heard arguments both for and against, reviewed common practice here in the United States, and the Christian approach to assisted death. So now we are confronted with the burdensome task of taking all this information, their own convictions, the sentiment of outspoken family members and colleagues, and now define or redefine your own platform and how you present this to patients and their families. If you are working at the details in your head and still trying to decide what you should do, you are not alone. If you already have a very strong stand on the subject, it may be a good time for you to revisit why. After all, it's not included in the curriculum of the majority of training programs, and if so, not enough. In fact, only 1/3 of final year internal medicine residents felt prepared to have end-of-life discussions with patients, and only 1% thought change in training was not needed. The need for medicine to be ethically balanced, due to the built-in imbalance of power, was recognized from the onset of modern medicine. The Hippocratic Oath makes that very apparent. But this balance remains dynamic and has changed considerably over the decades. We must remember that patients like David are not mere vignettes. They are the life stories of patients, friends, family members, and loved ones who are cherished. Even when we perceive the decision-making to be fairly simple, recognizing the need for empathy is crucial and requires tremendous sensitivity, as I cannot emphasize enough that no two cases are the same. How these patients and their families are engaged can both show the best and worst in humanity. Demonstrating empathy requires being present physically, mentally, and emotionally. There is no substitute for giving your undivided attention to a patient and/or their family. Your colleagues should recognize that importance and enable it. I would like to take some time to review a few key concepts that will help frame the approach to these patients. First, subsumed in the Due Process Clause of the 14th Amendment, a competent patient has a right to refuse life-prolonging treatment. An incompetent patient also possesses that same right when acted upon by a surrogate or a durable power of attorney. This includes ICU care, first aid and CPR, ventilators, inotrope suppressors, artificial nutrition, chemotherapy, blood products, or antibiotics. Next, based on the AMA Code of Medical Ethics, there is no legal distinction between withholding versus withdrawing treatment. The withholding of care requires the anticipation of medical circumstances. We are not talking about withholding care without the express directives of the patient in a non-terminal illness where we expect recovery after a period of time, probably in the ICU. There is a distinction of refusal of treatment or a planned withdrawal of care from assisted death, which is assisting another person committing suicide at the individual's request. For example, an individual grapples with the diagnosis of a late-stage terminal disease and makes informed decisions regarding advance directives, including to not resuscitate, as opposed to assisted death, where there is active participation by providing aid for the patient to terminate their life. Next, when we discuss end-of-life decision, the distinction between proportionate versus disproportionate means, which for intents and purpose of this discussion I will use interchangeably with ordinary versus extraordinary treatments, is of critical importance. There is more tradition that one is obliged to preserve life by using ordinary means. However, that obligation no longer exists when it comes to extraordinary means. One of the dilemmas of today is the blurring of lines between ordinary versus extraordinary treatment. Our patients today enjoy great success with treatments that are now considered standard of care, or in the not too far distant past, they would have been considered extraordinary. These are some of the great successes we celebrate today in several areas of modern medicine. We can expect to see this continue to take place as modern medicine continues to have breakthroughs in new treatments and interventions. Thus, the need for a continuous rebalance of what we consider ordinary versus extraordinary needs to take place. There, however, are several additional factors beyond the medical therapy itself to weigh into consideration, including religious, familial, social, and yes, even financial factors to be considered when deciding if treatment is proportionate or disproportionate to the provided benefit. Next, I'd like to discuss that placing yourself in your patient's shoes often allows us as physicians and healthcare workers to show compassion and empathy. I personally know many excellent physicians who do so. There, however, can also be a downside. Make no mistake, you are not the patient. Regardless of how many other patients with the same disease you have cared for, the burden remains theirs and theirs alone. It is our duty to recognize that this is unique to them. Jeffrey Figger, who is Jack Kevorkian's attorney, in the initial trials warned of the dangers of imposing your own beliefs upon your patients, and there is validity to that argument. This does not mean that you cannot pray with your patient if they are seeking it, as several studies have shown that spiritual guidance can be an integral part of palliative care. Now let's bring this back to our patient, David. Let's apply our scenario to the very first principle we discussed, in tandem with the 14th Amendment. David is clearly competent. He is educated and articulate about his request. He has had several years to adapt to his current disease and has come to accept his current state of health. Ventilator dependence is a life-prolonging treatment for him, and his right to refusal should be honored. The distinction should be made here between withdrawal of care, again, versus assisted suicide. Now I raise the question, does assisted suicide as physicians breach the tenet of do no harm? I believe it does, as it requires an action to be taken that leads to death, which does not satisfy the principle of double effect that we will hear about later during this presentation. As it does take a bad effect, essentially the result of an action causing someone to die, to bring about a good effect, which would be the end of their suffering. I also find it in direct contradiction to our primary role as physicians, which is to be a healer. we as physicians must aggressively respond to the needs of patients at the end of life. But that does not translate into engaging in assisted suicide. We should be present and available. We should respect autonomy. We should provide good communication and emotional support, and provide appropriate comfort care and adequate pain control. I hope this discussion will help create a framework with which you can navigate and approach your patients and your patient families, which can be some of the most challenging but also most fulfilling and meaningful patient encounters you may ever have.
To give us some final recommendations regarding end-of-life care, I invite Dr. Tony George, who serves as a pain management specialist in New Jersey. Dr. George.
Thank you, Justin. So in summary, we have a 34-year-old quadriplegic male, and he suffered this injury 9 years ago. We know his situation was stable for several years, where he enjoyed a relatively good quality of life. He was off the ventilator for extended periods of several hours. However, that has changed in the last 2 years. We see his recurrent admissions for pneumonia, requiring frequent suctioning and long periods of vent dependence. We see the patient himself acknowledging and recognizing how his situation has deteriorated over the last couple of years. We see that he is afraid of, in fact, choking on his own secretions. We also see the pulmonary care team and how they too recognize his situation is gradually deteriorating, and they are concerned about the long-term objectives for his care. He is utilizing extensive hospital resources. He needs recurrent bronchoscopies to remove secretions, which can be expensive procedures. He also needs to be on the ventilator for extended periods of time. And the ventilator is an external breathing machine, which can be a valuable resource for people who need it. And he is clearly utilizing and needing that resource for long periods of time. We see his condition, and we recognize that we can only empathize with him and see what can be done to help his situation. In his case, he needs to be kept comfortable. In pain management, the typical goal is to reduce a patient's pain, improve their function, and improve their quality of life. However, in certain situations, that can be challenging, his situation being one of them. In other situations, such as terminal cancer, where the patient is gradually declining, their functional status is not foreseeably going to improve. So in those cases, the objective becomes to reduce pain and to keep the patient comfortable. Pain medications are excellent choices to keep patients comfortable by reducing their pain. Some medications like sedatives are also excellent choices, as they work as good agents to reduce anxiety and also keep the patients comfortable. However, a drawback with some of these medications, including opioids, is that as they have these good effects, they also have bad side effects, which can be quite dangerous. Pain control is one objective, and it is achieved with these medications. However, one side effect we worry about is its effect on respiratory drive, how it can impair breathing and potentially even lead to death. Many fear and worry about these side effects of these medications and hesitate to start patients on these pain medications and even start patients on sedatives. However, we need to recognize in situations such as his, we need to think about the law of double effect. It is a good law to remember. It was first coined by Thomas Aquinas, a theologian, who recognized that there can be two sides to a situation. And the law has four parts. The first part is, or the first point is that the act itself must be morally neutral. The second part, or the second point, is that the bad effect should not be the means to the good effect. The third point is that the good effect should outweigh the bad effect. And the fourth point is that the agent intending to do the good effect should do so with the moral intent of intending the good effect. So in the situation, the act should be to reduce the patient's pain, and it is a morally neutral act. And to get to the objective of pain control should not be through the bad effect, meaning respiratory depression and any of the side effects should not be the way to achieve the objective of pain control. And third, when weighing the good and bad effect, the good effect should outweigh the bad effect, which is very similar to looking at risk and benefit ratio when we think about procedures. And the reason to do a procedure, we should see that the good effect or the procedure's benefit should far outweigh the risk or any of the side effect. And the fourth point is that the agent, which is the provider, physician, committing to the act, should do so with the intent of reducing the pain and reducing the patient's suffering. We know that pain medications in the literature have been described to prolong life. There are several studies that suggest it. Studies, most notably by Dr. Russell Portnoy, who is a pain physician out of Mount Sinai in New York, has described how opioid medications prolong life. We know situations where opioid medications can be harmful, and those are if a pain medication is started on high doses, or two, if they are rapidly escalated. And these are situations where the pain medications can be detrimental, where we can see the side effect, and that could be a concern. But generally, and the good practice is to start patients on low doses and gradually escalate their medications to the point where they're comfortable. So physicians start patients on low doses and gradually escalate the medication. From experience, even patients with cancer are sometimes placed on PCA pumps, which are patient-controlled analgesia pumps. These pumps have certain rates and certain intervals which they're set at. And these are also done to prevent these bad side effects. So, to summarize, he should be kept comfortable, and he should be started on low doses and escalated till the therapeutic effect is achieved. And I think in his situation, that is a very reasonable way to proceed to keep him comfortable through pain medications and sedatives, so that his quality of life improves. Thank you.
My next question is for Dr. Stanley Abraham, who serves as a pulmonary critical care fellow. From a pulmonary critical care perspective, what are some of the things we can do to alleviate this patient's pain?
Thank you, Justin. Speaking as somebody who works in the ICU, my recommendations are also based in my faith. Taking care of extremely sick patients is a difficult task, and it's important that we remember that we're not just treating a disease process, but also patients as individuals and people. This is where palliative care comes involved, and it starts from the moment that we recognize a patient is critically ill. The idea of beneficence and non-malfeasance was already talked about, but in simple terms, it's the idea of doing our best for our patients while also doing them no harm. Unfortunately, when a patient is critically ill, a lot of times the treatments that we offer can be burdensome to them and cause them discomfort. But we allow for these treatments in discussion with our patients and their families in order to treat them and with the goal of making them better and curing them of their disease process. Unfortunately, there are times that, despite our best efforts, we're not able to treat them and improve their disease process. This may result in prolonged illness or, unfortunately, at times death. Palliative care works with us through all of this process from start to the end to allow us to be able to take care of our patients well during the process of treating them, by treating their anxiety and their pain as they undergo treatment and deal with the burden of their illness, as well as when the time comes to ease our patients' passing as they unfortunately pass away. During the process of treatment, there are times, unfortunately, where as medical professionals, we reach a point where there's nothing more that we can offer a patient. It's at this point where we talk to our patients as well as their families and be truthful with them, telling them everything that we've been able to do and the progress that we've made, and unfortunately times the progress that we haven't been able to make, and the acute situation that their family member or they themselves are in. It's at this time that we talk to our patients and understand what their goals for treatment are. And we offer at times something called comfort measures, where we deal with their symptoms and the burden of their illness, their anxiety, their pain, their feelings of breathlessness at times, if that's something that's part of their disease process. And we allow them to easily transition towards passing away. There's a clear line that needs to be drawn between comfort measures, hospice, and physician-assisted suicide. Comfort measures and hospice care is not with the goal of hastening death, but the idea being to treat our patients and deal with the symptoms and the burden of their illness and allowing them to pass with dignity. At the end, the core of our belief and our ability to treat our patients and our drive to treat our patients must stem from us doing the best from start to finish. And that involves palliative care. That involves talking to our patients, treating our patients as people, and talking to their families and making sure that they are aware and involved in decision making. Thank you.
Thank you all for joining our podcast discussing end-of-life care and the topic of assisted suicide. Although we understand that this is a very challenging topic, we hope that by discussing the pros and cons of euthanasia and the role that a caregiver plays from a Christian perspective, we were able to shed some light and bring value to this topic. Thanks for joining us again.